Well, first I'd like to tell you something about the university where Jeff and I come from. City University of New York now is the third largest university system in the United States. But the thing that is unique about it is that it is all in one city. We have approximately 250,000 students, 250,000 students in one university in one city, with 25 institutions of higher learning. But the university also, which is the workforce engine for New York, the City University of New York also prides itself in graduate and professional education. And just as an example, we have about 35,000 graduate students, which makes us, in graduate education alone, almost the same number of all the students at Columbia University. So it's a very important workforce engine and training ground for leadership in New York. 60% of our students come from ethnically diverse backgrounds. And what is significant, because we are very fortunate in living in a wealthy city, in a wealthy state, we are able to support 60% of our students paying no tuition and 80% graduating without debt. That in America is in itself a miracle. So Jeff and I and others like us, the 50 faculty in the CUNY Graduate School of Public Health, are drawn by that mission of public service. And as such, during COVID, we found it very essential for us to be engaged with New York and New Yorkers. New York was the epicenter of the COVID pandemic in the United States, like Rome was early on in Europe. And obviously, this was a very good example where populations of diverse backgrounds and populations coming from underserved neighborhoods paid a much higher price. Yesterday, we talked about people having to use public transportation, people living in crowded housing communities, and people engaged in service where they could not afford to work from home, and as such paid a much higher price in life loss and in disease and economic consequences than the rest of the population. And I'm going to today talk a little bit about what we learned, and our engagement was with New York City, was with the United States, and was global. Today's presentation is about a series of research projects that we started to conduct in 2020 and did a series of global surveys in 23 countries involving about 23,000 respondents every year for 4 consecutive times. The very first, Jeff alluded to, was a study looking prospectively at the acceptance of the COVID-19 vaccine, whether people would accept it if it ever existed. And that became a highly frequently cited reference to many people, but the bewildering aspect of it was that it was fairly accurate in predicting how the global response would be to the vaccine. So asking people before the vaccine was there whether they would embrace it turned out to be rather predictive of actually how much of them would. But we did not only focus on vaccines, because vaccines alone, whether they are adopted or not by individuals, are also affected by mandates that include vaccination at the workplace or vaccination during travel, but other mandates that restricted people's mobility, mandates that enforced wearing masks, and mandates also that prohibited people from gathering in public spaces where they ordinarily would worship or play or study. And as such, these mandates were received sometimes with very low levels of enthusiasm. We tried to understand better why people accepted or did not accept, and made comparisons along these preventive measures globally and locally And obviously, one of the things that were very striking, as you're going to see, is that there's a very wide range in the global arena. But also, more importantly, even within the United States, one of the strongest predictors of vaccine acceptance or acceptance of wearing the masks were mediated by political affiliation and political ideology as the strongest predictive variable. More than education, more than age, more than gender, more than economic factors. So talking about these mandates, we define them as legally enforceable policies designed to protect public health and safety during a crisis. And examples, as I said, included vaccination requirements in certain groups. And obviously, as a physician that worked in an intensive care unit all my life, I was mandated to be vaccinated against many diseases to protect my patients. But the public is not accustomed to mandated vaccines. But again, as alluded yesterday, quarantine protocols and restrictions on public gatherings were to many people a very new thing that they had never experienced before. As I said, ideology, the belief system, adherence to what is considered autonomy and personal freedom drove people to either react emotionally, sometimes not very logically, to what was felt to be an encroachment on their personal freedom. And that overwhelmed the sense of community responsibility in certain times. It was interesting that we looked, for example, at acceptance of vaccine mandates from governments, and we continued to ask that question over 21, 22, and 23. And this is a comparison of the 23 countries that we studied during that period of time. And it shows you that the acceptance of vaccine mandates from governments actually, as you are going to compare to mandates from employers and others, that the acceptance of mandates from governments actually were the highest. People were more likely to accept mandates from government than they were from other sources. You will see over and over that in China and in India, people were most likely to accept mandates compared to other countries from the outset. If you compare Germany, which is the sixth country from the left, for example, or compare it to Russia or Poland, you'll see that people's acceptance of these mandates to begin with were amongst the lowest when compared globally. So even in 2021, only 41% of people in Germany that we polled responded that they did accept government mandates for vaccine, compared to 96%, 97% in China. And when you see in India also almost 88%. So there are very important global differences. And as we know, in a pandemic such as this, the global response is just as important as the local response sometimes. And we in New York, being an open city, not having any restrictions early on people coming to the city, and then eventually requiring some vaccination mandates, may have presented ourselves like other cities and other countries, requiring such mandates as having created a barrier for people that some chose not to cross if they visited the United States. So as you see, global average of acceptance of vaccine mandates from government were amongst the highest. On the average, it was 62% in 2021 and declined over time to 55% by 2023. If you look at acceptance of mandates from employers, you see a very similar pattern, although the numbers themselves may be slightly lower, but you see that acceptance of mandates from employers changed dramatically over time. And when you look at 2023, which is the darkest blue, you see that it drops very significantly. Sorry, I didn't. Dropped very significantly For example, in a country like France, or even in China, where early on they were more than willing to accept mandates from employers. But as time went on, if you look at a country like Turkey or Spain, the dramatic difference over time in people willing to accept mandates. We in the United States today, and I think Melinda and Jeff may be aware of that, have people that have lost their jobs because they were unwilling to accept the vaccine mandates, that are currently suing their employers and winning cases in court against them. With the change of sentiment and the change of political and ideological milieu, it would not surprise me that more and more people will collect compensation from employers that dismiss them because of lack of compliance to vaccine mandates early on in the pandemic. The global average for acceptance of vaccine mandates, as you see, from employers is less than it is from government, and by 2023 declined to 1 in 5, 21%. If you look at acceptance of vaccine mandates for school children, which was a major, major controversy in many countries, including the United States, with people, even child development specialists and educators, saying that, you know, mandates both for vaccination and for learning from home were really creating mayhem in the continuity of the educational process. And that parents that did not want to accept these mandates were then, the children were held at home and were not able to participate in classroom activities. And as you see, in this case, for example, you see more countries early on with less enthusiasm. France, Germany are examples, but also Poland and Russia again. But when you look even at countries like Singapore or the United Kingdom, the level of enthusiasm for mandates keeping children at home is less. And on the average, it was 58% in 2021, declining again to 21% in 2023. Acceptance of vaccine mandates of university students was slightly better, although the same countries had the same distribution. And we, as the City University of New York, went into mandates for vaccination, although the students were learning from home, distance learning, and which in itself was a major obstacle in a university that serves populations with low resource. Students, City University of New York distributed 50,000 laptop computers in March of 2020, between March and April, in order not to disrupt the educational process in the spring semester of 2020, because many of the students did not own a laptop computer. But unfortunately, that alone did not solve the problem, because many students sometimes did not have private space to study at home, and in many instances, their families or their friends could not afford the kind of internet capacity that allowed them to participate in high-quality distance education. So nonetheless, acceptance of university mandates was higher than the acceptance of school-age mandates for vaccination, being at 63%. But you see the magic number in 2023 is almost 20%, 1 in 5 consistently would accept such mandates. That in itself, as we're going to describe, is a manifestation of fatigue. Masks were another big controversy around the world, and masks, not unlike vaccines, were associated with a lot of mis- and disinformation. Most of this material is published in our articles, but obviously I have summated multiple publications in these slides comparing over time. But as you see, the enthusiasm about masks was not at the same level as acceptance of vaccine, and but nonetheless we are seeing that as a less intrusive intervention, the drop in acceptance, even by 2023, is less prominent We're now not at 20%. Sorry, but this is not over time. This is in different environments. In government offices, it was 65%. Enforced by employers, it was 41%. And in universities, it was 31%. So again, where people are wearing masks and who can impose mandates on people to wear masks differs significantly by location. We still are seeing people wearing masks, but it's a very rare occurrence in our school. Some of the faculty continue to wear masks occasionally, but it is a very rare occurrence. I don't know how it is in the environments where you're working or where you live. As I said, there are many factors that influenced mandate acceptance, and there is no question that trust in authorities was a major issue. And as we were transitioning into, for example, a democratic government after the first Trump presidency, people who held Republican affiliation were less willing or less likely to accept mandates imposed during the Democratic government presidency. There were many safety and efficacy concerns. There was a lot of misinformation about people more likely to get sick when they wear a mask. I don't know how this was in your countries, but in the United States, there was a lot of misinformation about wearing masks. And in some instances, I was talking about the role of a public university in a city like New York. We were consultants to two bodies in Broadway. One body were the performers, the musicians, the singers, and the actors, and one was the producers. And although it was the same industry, the difference in their interest in this matter governed their response to vaccination mandates, wearing masks in the theater, et cetera, The producers wanted a more liberal approach so that they would have a bigger audience and a better profit. And of course, the performers were more concerned about infecting each other. And it's very interesting because it took a lot of work on our part to measure droplets for people who are singing versus acting, whether they were yelling or just speaking quietly. And all of these things were imposed on performers in Broadway at the time, and because of their self-interest, we felt like the performers were more likely to accept such mandates than the producers were. As I said, misinformation played an important role. We are now in the epoch of fatigue. People don't want to listen to anything about an infectious disease or a pandemic or an epidemic. We are currently in a very early phase of an H5N1 outbreak in the United States, slowly moving from animals to humans, and people just don't want to hear about it. We just did a survey of 4,000 respondents in the United States trying to understand how people were willing to accept vaccines or restrictions, and maybe another time. We're in the process of publishing the paper. People are really very sick of the topic. And again, in that particular instance, it targets certain employments, people who work in dairy farms, people who work in chicken farms, and there is a conflict between the FDA and other regulatory agencies that work with this industry, and between the interest of public health professionals like ourselves. And these people don't normally work together well or speak to each other sometimes at all. But pandemic fatigue encompasses emotional exhaustion from long-term health restrictions, reducing motivation. Vaccine and information fatigue also arises from the declining trust in the necessity for the vaccine over time, especially when the recommendations become less for boosters and recommending boosters only for certain age groups and certain vulnerable groups and not across the board, diluting the enthusiasm for vaccine boosters. And obviously, the economic factor was very severe. It was very amazing. I live close to 6th Avenue on the west side of downtown New York, and looking at people dressed very much in ways that you would expect middle-class people to be standing in long lines for free food was rather daunting. I'd never seen such long lines of very well-dressed people trying to collect free food. So the memory of transitioning to a position of vulnerability caused by an infectious disease left people with a level of trauma, I would say. So we asked people on this global study, over 30% of individuals exhibit disengagement from COVID-19 vaccine information. And as you see, we asked that question, for example, in Mexico, it is shocking that people may be less interested in paying attention to any more information. And that puts the burden upon us in the area of health communication, health information systems, as to how we can continue to allow people to be interested in what we do. I know Michael yesterday talked about giving food early on during vaccine campaigns, but even that becomes kind of less enticing over time. Which brings us to the issue of strategies to improve compliance in general with public health mandates. And the findings we had in the very important study that Jeff also alluded to yesterday in terms of the overall consensus, post-COVID consensus, said that we need a whole society and a whole government approach so that there are no conflicts between government agencies and that there is a social movement that is adopting safe behaviors. That did not necessarily occur in a very easy way during the pandemic. And I would say that government agencies, the model in the United States, and I'm sure that is true in other countries, it's not like government agencies sit around the table and say, oh, you know, transportation, I don't need money this month, I'll give it to health. That's not the way it works. People are always competing for resources. The budget is set, the budget is not very elastic. And so the idea of a whole government approach requires very new policies and very new politics in government. And I wonder when that is going to happen. The other thing in communications was the lack of consistency. People regarding public health agencies to be arrogant. I think the CDC made many missteps by changing its mind about things when originally it could have simply said, I don't know. I don't know is a very good answer, by the way. But we, you know, I will say about myself, you know, we academicians and scholars feel very vulnerable saying, I don't know. We always want to have an answer. And by doing so, we set ourselves for lack of trust with the people that listen to us, because then when we know, we give information that is more certain, but sometimes contradicts what we said originally. The second thing is that we didn't listen to people as to what they needed to know about, and we were less empathic. Our School of Public Health is in Harlem, and when we did community-based post-COVID surveys, some of the things that we heard were totally surprising. Families said that during COVID closure of businesses and businesses going out of business, when there was one shoe shop in certain parts of Harlem, kids were outgrowing their shoes and the parents didn't have a place to buy bigger shoes for them. Who even thought of that? Who would think that that had anything to do with the pandemic? But it was expressed by multiple families that they had a shoe crisis. as their kids were growing up over a period of 2 years, they outgrew their clothes, they didn't know where to go, and these communities are very microeconomics invested. They buy from their local stores, they are unfamiliar with stores outside of their neighborhood, and they find these stores outside of Harlem to be unfriendly and culturally inept and not welcoming. So it's not like it's easy for them to get on the subway and go to New Jersey to buy shoes. So, you know, it's these things, especially amongst low-resource communities, are very important in active listening. Listening as, how much time do I have left? I am out of time. Okay, well, we're almost equitable enforcement. Again, the sense of fairness is very important. And people felt like those that were lower on the totem pole, either in the workplace or the kind of work they were involved with, were more likely to be penalized, to be terminated, and to bear the consequences more than people who are more financially empowered. So we need to engage in these trust rebuilding mechanisms, need I say, more than trust building. And the response reveals the necessity of addressing misinformation very directly, monitoring it and counteracting it rather than complaining about it. And then equitable enforcement of strategies needs to be thought about much more seriously so that communities of low resource don't feel that they have been targeted. And with that, I end my presentation, and forgive me, Jeff, for overstaying my welcome at the podium.